All right, we'll go ahead and get started. Once again, welcome to you all who are just joining us. My name is Leanne Foster, and I'm a provider outreach and education specialist here at WPS. And I'd like to welcome you all to our Strolling the MDM Boardwalk, Categorizing Data Reviewed Part 1 of 2. Now, I did mention that this is Part 1 of 2. In April, Ashley and I kicked off our level of service series and have been breaking it down further in the last couple of months. So if you haven't had a chance to see our choosing your appropriate level of service webinars or the session that we did on problem, certainly those recordings are available on our YouTube channel and actually on our Encore page website if you'd like to see those. Now, today we are going to be focusing on data. Today, we are focusing on providing an understanding of the data element when using MDM to select the appropriate level of service. So we're focusing on data and we're focusing on using MDM to choose your level of service. We're going to do that by breaking down the data element, and we're going to talk about the levels related to data. We're also going to talk through some examples of counting data, including what is going to count as unique, what is going to count as discussion, and we did receive quite a few questions on independent interpretation, and we'll talk through all of those today. Now, as I mentioned, this is a two-part series, and today we're focusing on the concept and building that knowledge on counting data and using data for MDM. Tomorrow, Ashley is going to be leading an interactive session, and if you've attended any of our other sessions, you know that session is going to go over some common rejections, denials, and just general claims information involving data. And it's also going to allow you the opportunity to apply your knowledge from today through an interactive activity. So if you've not yet registered for that and you are interested, registration is still open, and I've asked Ashley to place a link in the chat for that. So I am going to start off with an overview of MDM. Again, not knowing who's in attendance today from our earlier sessions, we want to make sure that we're starting with a high level of MDM just to set the baseline for today. So first and foremost is the key determinant of coverage, and medical necessity is that initial determinant of coverage. We have to know whether or not the service is medically necessary for the patient. So per the Social Security Act of 1935, specifically Section 1862, services must be reasonable and necessary to treat an illness or injury or to improve the functioning of a malformed body member. And if you'd like to take a further look at that, if that's something that's new to you or you'd like to reference that, I have included a link for that. But essentially what that is saying is that the services must be reasonable, they must be medically necessary, and they cannot be statutorily excluded. There are some services that are just statutorily excluded from Medicare coverage, and they're not going to be paid ever unless that exclusion changes. And how do we determine this? Well, it's all going to be based on your documentation. If you've attended any of our sessions before, or certainly throughout today, you're going to hear me talk about it has to be supported by documentation. When our reviewers are looking at these claims on some type of a claim review, if it's not documented, it's not clearly documented, it didn't happen. So you want to make sure that your documentation supports this. Now, certainly we're not looking for an entire novel of documentation, but those key pieces that support the level of service billed, the CPT code that is billed, need to be clear in that documentation. So they need to show us what you're doing for that patient and why does the patient need your services or the services that you're providing them in this encounter. So that is always going to be that key theme is documentation. Again, if it's not documented, it didn't happen. We cannot make assumptions. It has to be clear. So when choosing your level of service, the majority of time, you will get the option of choosing your level of service by time or MDM. We did in the spring do a session on time, so if you're interested in that, that recording is also available. But MDM and the data element is what we're focusing on today. So when you're using MDM, like I said, there's a choice between time and MDM for most services. There are some exceptions, but you want we'll often get questions about, is it better to always choose time or always choose MDM? And the answer is really, it depends. I know that's not necessarily a clear cut and dry answer, but it really does depend on what's most appropriate based on the patient's need and what was done for them in that encounter. So it's not as simple as always using time or always MDM. You may not always use time or always use MDM on every encounter for the same patient. It just depends on what their needs are. So it varies by office, it varies by patient, it varies by encounter. As I mentioned, there are some exceptions, and those are going to be critical care and emergency department services. So with those exceptions, emergency department, those codes are going to be MDM only, not time. And this has a lot to do with just how those services work. And with an emergency department service, they're likely going to have multiple encounters. They're going to be working with multiple patients at the same time, and it's really just hard to just keep track of the time. So with emergency department services, those codes are determined by MDM only. With critical care, this is determined by time only. And I've included the codes here for reference, but with critical care services, we're already assuming, or it's already built into the code, that those services are being performed at a high level of medical decision making if you're needing that critical care. So the elements of MDM, getting back to that, are problem. And with problem, it is assessing the patient's status and condition, and you're going to be, well, without MDM in general, and looking at any comorbidities that they may have. You're establishing a diagnosis, although it may not always be a specific diagnosis. You may be establishing that they need more tests. The diagnosis may be their symptoms. It may be their chief complaint, the condition that you're observing today. It may not be a final diagnosis. And then you're also going to be looking at establishing their treatment or management plan for their condition, and going to need to assess that risk. So it comes down to three things. It's the problem, which is the number and complexity of the problems addressed. You're going to be looking at data, which is what we're focusing on today. So the amount of data and the complexity, what work was done, how many tests were reviewed, what's the complexity of that data. And then we do have an upcoming series on risk, but with risk, you're looking at their risk of complications, morbidity, or mortality from what's occurring with the patient. What's their care management plan? What are the medical decisions being made? The risk is going to need to be assessed. But again, today we're focusing on data. So with that, let's look at data analyzed. Now, to set the tone here, data is going to be part of that medical thought process. It has to be documented. That documentation is also supporting the medical thought process the provider went through in identifying the needs of the patient and creating that management plan. One thing I do want to call out is going to be that tests ordered in a session are going to be presumed analyzed when those reports or those results are reported, when they're available. Because of that, they are counted as ordered and reviewed in that encounter, and that'll come up a couple of times today. But the practitioner is going to be analyzing them during that encounter. We do run into situations where maybe they're ordering a series of tests. We did get some questions on that. They're ordering a series of periodic tests. Maybe they're not expected to come back in for an encounter for 6 months, but they're having a certain test, maybe it's their glucose. They're having their glucose checked every month between now and then. The order and review is counted in the first encounter where it was ordered and reviewed, but the review of those additional tests can be counted in the encounters in which they're used. So that's something to keep in mind as we get into this. But those tests, that data, whatever that happens to be, is going to be used in determining and assessing the needs of the patient. What's their diagnosis? How are we evaluating them? What's the treatment plan look like for them? With data, just like problem, and as you'll see in a future session, risk, there are multiple categories per level, and those categories are going to represent an increased increased level of review, uh, an increased level of analysis. It could be that there's more tests, there's more data, there's more notes, there's different types of data that they're going to be looking at. So as I mentioned, when you're counting data, it is assumed that it is analyzed and reviewed in the encounter in which it's ordered when those results come in. So they're analyzing that same. They're counted in that encounter that's used. Where it gets a little bit different, I mentioned again that series of tests. So if you have something that is ordered outside of the encounter, maybe the encounter occurred, results came in a week or two later, you need more tests, those are going to be counted in the encounter in which they're analyzed, where they're going to be used. Also, there are going to be times where there is data from external sources, and we'll talk about what that looks like. But external sources, again, those will be counted in the encounter where MDM is being used to choose that level of service. The other thing with counting data, you want to make sure that you're not double dipping. So make sure you're not counting data. This can happen with reviews, and we'll talk about that independent interpretation, but you're not counting data that's being billed separately. If it's being billed separately, say there's a professional component, that review's already been considered. Now, this is where we get to one of our first pre-submitted questions. The first one that we received was asking, does considering a test count, even if it's not actually done? This is an excellent question, and the answer is yes. If that test was actively discussed and considered in creating the plan or in that patient's care management, it can count, but the documentation needs to support that. Now, an example could be maybe there is a particular blood test, maybe there is a particular imaging test that you're considering, and maybe looking at the patient's condition, maybe there were risk factors that caused you to maybe think maybe that's not needed, or maybe another test came back and that test is no longer needed. It was still considered, it was still analyzed, that was still would still be something that, even though it's not ordered, it was actively part of creating their care management plan, and it can be counted. But again, it has to be documented in order for the documentation has to support it, documented in order to count it. So I do want to talk just a little bit about tests. We did get some questions about what counts as a test. So as you can see here, a test is defined as imaging. Uh, Now with imaging, that can include independent interpretation, which we'll talk about in a few minutes, but that's there. It can include lab tests, it can include psychometric tests, or physiologic data. Unique is essentially broken down by procedure code. So if, for instance, and we'll talk about this a little bit in a minute also, but if you're running multiples of the same test, maybe you need it run every so many hours, it's still the same test. So CPT is pretty clear on this, that they define it by that CPT code. Okay, so they are stating that if it's that series, you're not ordered by that same practitioner, a member of the same group, and the repeat tests, you're not going to count those separately. You'll also see here that I just want to point out pulse oximetry is not something that is counted as a test. That's something that is pretty common, and it's not really a test. It's kind of a standard procedure, and it's part of that. It's included in part of that encounter. It's not counted as a separately ordered test. So unique, as I just mentioned with unique, it's defined by procedure code. And we did receive a few questions that I want to address on that. So when you order that test, that review is part of that test order, and you're not counting it twice. So with overlapping, we'll get to an example of lab panels. What I just said is if you're ordering multiple of the same test, that's still one test. Now, unique source, CPT defines unique source as a physician or other qualified healthcare professional in a distinct group or different specialty or subspecialty or unique entity. So a unique source is not someone in your own office or with whom you share medical records. It does need to be somebody in a different specialty, in a different group. Okay, so keep that in mind. Each source is going to contribute unique information that's going to help in determining that patient's plan of care so it can be counted if it is meeting that definition of unique. And typically, we got a lot of questions about review of materials. So review of all materials from any unique source is counted as one. CPT lays this out pretty clearly. One of the questions that we were asked was when reviewing data from a previous emergency department visit, does all the data count only as one record? So you're looking at those materials as one, okay, because it's one unique source. So I did want to include an example of this because I know that this can get a little bit confusing. So here I have listed 85025 as a single test. If it's ordered as a single test, even if it's ordered multiple times, it's one test. If that is ordered in conjunction with a panel that includes multiple tests and that lab panel includes 85025, you're only going to count the 85025 once. So that lab panel includes it, you're counting the lab panel. You wouldn't be counting the lab panel and the individual test. It's not counting twice. Next, I do want to talk about the definition of external. So this is going to be uh, something that's coming from outside of the entity or a member of your group who's a different specialty or different subspecialty. So somebody that doesn't fall into that definition of same provider. This is not reviewing your own previous notes. That doesn't count as external. And external records are going to include just the notes. Those external records could be communications, could be test results from an external physician or other qualified healthcare provider, could be from another facility or a healthcare organization. And one question that we did get is uh, what counts, and that other qualified healthcare professional is going to be your non-physicians. It's going to be somebody that uh, is going to be involved in that patient's care. So here again, I've laid out what that external looks like. We did get one question about a statement that is being seen in medical records. So the question is, can this statement count as data reviewed? Many of our providers put this statement, and the statement is, I personally reviewed outside records from the patient's primary provider. So there's nothing really wrong with that statement, but it depends on depending on what's being billed, it may not be enough. It states they reviewed those records, but we need to know what was reviewed and how it was used in the management of the patient's care. Just stating that you reviewed it might not be enough. Again, just depending on what is billed. So best practice, maybe in addition to that statement, would be to add just a few specifics about how it was used and maybe what portions of it were used, because those previous notes may not, everything in them may not be used. It may not be clear on how they were used in the encounter today. So again, nothing inherently wrong with the statement. It just might not have the level of detail to support what was billed. And that's going to vary by encounter and by patient. Next, I do want to talk about discussion. This is part of category 3 when you get into some of the higher levels of data that we'll talk about here in a minute. Discussion is a real-time discussion between practitioners. And this could be, say, the cardiologist discussing an aspect of the patient's care with the internal medicine provider, but it has to be an interactive exchange of information. It's not exchanges of medical notes in that medical record. This is actually going to be two people having a conversation in some way. Now, it can be text message, it can be asynchronous where you're leaving a message and they respond in a short period of time. CMS does not lay out a specific period of time, but typically uh, we're looking at a couple of days here. We're not looking at weeks and months out. So you want to make sure that that is documented, that there was that direct exchange when it happened. It also has to be something that is with an appropriate source. And we did receive a question on what is considered an appropriate source. That would be, for CPT, an appropriate source is going to be that external physician or other qualified healthcare practitioner. So again, I'm going to go back to those non-physician practitioners, physician assistants, nurse practitioners, but it's going to be a practitioner that is involved in the patient's care and they are not separately reporting a service. So keep that in mind. But like I said, it doesn't have to be on the same date of the encounter, but in a couple of days to a week, but it's not documented that it has to be in a set amount of days. Everything that's documented from CPT to CMS is a short period of time. The other thing that you want to make sure that the documentation is clear on is that uh, what that discussion was. We did receive a question about when discussing the management with a provider, does the documentation need to state who that provider was? The answer to that is that that documentation does need to be clear about what discussion occurred, as I just said, but who did you have the conversation with and what was discussed and how was that used in the patient's care plan? So we do need to understand that. When did that happen? Because we're looking for that. How did it happen? Was it a text message? Was it a phone call? Was it face to face? But again, it has to represent that direct discussion. So next we're going to get into the levels of data. So we talked about the levels of problem. Now we're getting into the levels of data. Levels of problem we talked about in a previous session, but they are the same levels of data of that we discussed in problems. So the level of MDM is going to be straightforward, low, moderate, and high. Now with MDM, the level requires 2 out of 3 elements be met when you're looking at the chart inside the CPT. And keep in mind, it's going to look different based on the patient, based on the condition, based on the encounter. So you want to make sure that you're looking at that independently every time. So starting with straightforward. So straightforward data is going to be, there's minimal data or there's no data required for that encounter. So this means that maybe no tests were ordered, no tests were reviewed, no notes from a previous encounter were looked at from an external provider. They're coming in with a pretty straightforward problem. The example I'd use here would be they're coming in with a cold, they're an otherwise healthy person. You can tell from taking their vitals, they're all stuffed up, they're sneezing, they're coughing. You can tell that's what they have. You don't feel the need to run a test for strep throat or anything of that nature. So I do want to call out, I'm not going to have examples of this because this is little to minimal, no data. Now we move into low or limited data. This is a little different. You're going to have 2 categories to choose from here, and you must meet the requirements for one of the 2 categories. This isn't 2 of the 3 bullets, but at least 2 items described in those bullets when you're looking at the CPT. So ordering 2 unique tests would meet. It doesn't have to be 2 of the bullets. The bullets are the examples of items that if you have 2 of them, you meet the level of data. So looking at those categories, we're looking at category 1, which is going to include tests and documents reviewed or analyzed. And then category 2 is the need for an independent historian. Now with an independent historian, this comes into play if it's needed because that patient cannot provide a complete or reliable history. Maybe Maybe it's age related, maybe it is related to their condition, maybe they're not communicative, maybe it's someone that has Alzheimer's or dementia, something of that nature. But there needs to be documentation as to why an independent historian is needed in that encounter for that patient. And we did receive several questions regarding specifically that age limit for independent historian, and I want to call that out. The question was asking, can you give credit for parents providing history up until the patient is 18? And some were just asking purely for an age limit in general. And there's not an age limit. CMS doesn't call it out. CPT does not specifically state it. And it's not set by age because, again, you could have a parent giving that independent historian piece be for somebody over 18 because maybe they're not communicative. It's a matter of what's going on with that patient. Okay. This is not going to be just, say, a spouse or um, a child adding information during the encounter. This is going to be that independent historian is needed to help facilitate that encounter. And again, needs to be clear in the documentation why it's needed. But again, there is no age restriction on that. So here I have an example of what lower limited documentation may look like. There's not a template. There's not um, our reviewers are following CPT, but there's not a one size fits all for what this documentation looks like. So this is an example from a review where code 99214 was billed. So in looking at the documentation, which is the image that you see here on the left, the documentation, I don't have the whole portion of the problem, but the documentation did support a moderate level of problem. Uh, they it did support a low level of data, and that is shown in the with the green boxes. The top box is showing that we're in the assessment of the plan section. That's where this information was found. And then I have the bottom two boxes are supporting what that plan was and what that test was. And their plan was to have a LexiScan of the back in 6 months' time. So that is the plan. They've ordered one test. That is going to meet that category 1 data or low risk. Because of that, they build a moderate level of code, but it was down coded to a 99213. They had a moderate problem, but you have to meet the 2 out of 3, and here they're meeting the 2 categories for low. So moving on to moderate data. So when you start looking at moderate, we now have 3 categories. And here you must meet one of the 3 categories. Again, not necessarily all 3. And to meet a category, you need to meet the items listed under that specific category. So for category 1, it's still going to, it's a combination of 3 listed. And category 1 is still going to include the review of notes, the order and review of testing, but now it's also going to include that independent historian, so that's moved. And for category 1, as I said, you have to meet 3 of the items listed, any combination, not just by the bullet. So if 3 tests are ordered, you meet it. You don't have to have an independent historian. You may have one. It's just going to depend on what's going on in that encounter. Category 2, this is going to be that independent interpretation of tests. This is going to be an independent interpretation of a test, which is not being separately reported. So if you're not going to count, if the provider's billing for the professional component, that interpretation is already being encapsulated in the billing of that interpretation for that test. But documentation must support the independent interpretation of that's being done by the provider that's counting it. It does not have to be at the same level as, say, a radiologist, but it does need to be clear. We did receive uh, quite a few questions on this. So hopefully I'm going to run through those and hopefully this information will be helpful. So the first question that we received is, if the physician orders a test, can they also get credit for the independent interpretation? And the answer to that is yes. However, as I just said, it depends on if they're separately billing for it. So if the provider is not separately billing for the professional component, they ordered the test, the provider could do an independent interpretation for the test, document that independent interpretation, and they could both count. They order it, radiologist does their interpretation of it, then the provider does an independent interpretation, again, documenting that. This is not just reviewing and saying, yes, I agree with the radiologist. So we don't have a template. I did get asked that question a couple of times. We don't have a template or specifically how that independent interpretation looks should look. CMS nor WPS provide any kind of template for that. And it's going to be different for all organizations, all providers, all tests, how they do that. But the key here is going to be that they're showing that they're doing an independent interpretation of the test, not simply reviewing a radiologist's finding, for example. They're showing that personal review. They're showing their specific findings, what they are gathering from that test, and then they're going to document um, how they're using that in that patient's plan of care. There does need to be a report. Like I said, it doesn't have to be as detailed as, say, the initial interpretation would be, but again, it's not just a review. We also had a question about whether or not nurse practitioners and physician assistants can count as independent interpretation. And the answer here is yes, as long as performing that independent interpretation is inside the scope of practice for their state licensure, and that can vary. So you want to make sure that that is something that they're legally able to perform. But yes, that is something that can be counted there. The last question that I wanted to address here was independent interpretation of a test performed by another physician or other qualified healthcare practitioner, not separately reported. The question is, does the other physician or qualified healthcare professional need to be from a different practice? So they'd need to be, generally speaking, they're going to be from a different practice. They may not be, but it just needs to be clear that they're doing that independent interpretation and they themselves are not separately billing that. Then moving on to category 3. Category 3 for moderate data is going to be that discussion with an external physician. And we just talked about what external looks like, what that discussion looks like. So that is going to be your category 3. And again, with moderate data, you need to meet one of the 3 categories. So here I do have an example of what portions of a medical record that meets moderate data would look like. Again, not the entire piece, but just some of the highlights of what we're looking for. So in this case, what was billed was going to be the 99214, and the documentation did support that moderate level. In the problems list, they did report, or they did have enough information to support a moderate level of problem. And here I am showing the excerpts of the data. That top image is documentation that's showing uh, showing that moderate level of problem, but it's also showing that evaluation. The second or the middle images, those are going to show the review of prior notes and the review of tests. We're looking at the dates. It's showing that these tests happened in the past and that they're looking at those. And then that bottom image is showing the ordering of tests. They did order additional tests. So in this case, they are meeting category 1, which is 3 tests, because it includes the review of the prior note, the review of the tests, and then they ordered a test. So this is how that's documented. And when looking at this documentation, I was looking throughout the entire document. It wasn't necessarily all laid out in bullet points in one spot. Sometimes we do see that. Again, it just depends on how your organization is documenting this, but we are looking through the reviewers are looking through all of that. looking for those specifics. And as you can see, it's not a novel, it's not pages and pages, it's certain pieces that have made it clear what has happened. For a high level of data, it does change. This is going to be extensive data was used for MDM. Lots of tests, lots of notes were reviewed. Maybe there's lots of discussion. It's not necessarily just amount, but that does come into play. So for high, you have to meet at least 2 of the categories. For category 1, you must have 3 of the items listed in the bullet. So it's any combination of those 3. But again, you have to meet 2 categories. So if you meet category 1, then you also need to meet category 2 or 3. You may meet all 3, it just depends. With category 2, this is going to be that independent interpretation of tests. Again, that documentation has to support that independent interpretation of those tests. Category 3 is going to be that discussion of management with that external provider or other, that qualified health professional, whether that is the physician or those non-physician practitioners, but someone who meets that qualified health professional. But again, you're meeting 2 out of 3. Unfortunately, because we only have the documentation examples for the reviews, when reaching out to our medical review area, they did not have examples of high data. It's not something that was available to us at the time, but it's going to look much like the moderate level that we just spoke about, but you're going to have an increased number of tests. You're going to have that independent interpretation, or you're going to have that discussion. Remember, those levels are showing an increased amount of data, increased amount of analysis in that. So before I check in with Ashley, I do want to call out some resources that we have made available to you. We do have that evaluation and management services guide that CMS has. That is always a great resource for providers to take a look at. We do have a resource to our Chapter 12. Now, that is our claims processing manual. Now, CMS is following CPT guidelines for data. We did get one question that was referencing a counting of tests from an external source. It was referencing a chart that was not CPT. It was something that was modified a little bit. I would refer to that CPT chart. That is the one that CMS is going to follow. I did look at the chart that was provided, and it is a little bit different. It's just higher level, and CPT does include definitions of the items that we talked about today. One thing that we do have out there as well is an evaluation and management services page. I did include that link, and I'm just going to go ahead and go there. Sorry, that opened up on my other screen. This is the CMS evaluation and management services page. So there's a lot of great information that is out here. Particularly, it does have a lot of information on documentation and service levels. So there are things that are of value for you. We also have the CPT evaluation and management guidelines. And that is a resource with the AMA. It just kind of breaks down some of what we've discussed today. So that's also a resource that you'll want to take a look at. And one other item that I do want to show you, sorry, I clicked on the wrong button there. On our WPS website, in our training center, it's the easiest way to get to it. If you scroll down, we do have a specialty service training and resources page. And from here, you will find that we do have a resources page specific to evaluation and management services. I'm going to throw that link into the chat. so that you have that. But this is a page that actually has all of those links that are also in that presentation, along with additional resources for other topics concerning evaluation and management. But this is also a really good resource for you for selecting your level of service. And there's some resources for data here too. So with that, I am going to check in with Ashley. I know she was addressing some questions. I know I addressed some of the independent interpretation questions that we saw in the chat earlier, but Ashley, do we have any questions in the chat?
Leanne, we just have one question that's come in that has not yet been answered. And this question says, if the provider is reviewing notes from an outside health facility, say an ER with labs and images, is the provider still able to get independent interpretation of images if documenting within their encounter, or only the external note review credit?
I would say if they're doing the independent interpretation of those tests and they're documenting the independent review of those tests, they could count for that independent interpretation. But again, it can't just be a review of the notes, just a review of the previous interpretation. It has to show the provider's own thought process, their specific findings, and how they're going to incorporate that into the management of the patient's condition.
All right, and all other questions have been answered.
All right. And I see that there were quite a few questions that were answered in chat. What we will do is I will send up a follow-up document that has those chat questions and those answers so that all attendees will have those at their disposal for reference. Now, if you think of any questions in the next 7 days, Ashley and I are still taking those questions. This isn't certainly the end of your ability to check in with us for questions. I am going to have Ashley here in a minute throw the education mailbox email address in the chat again. You can, just like you would with technical issues, you can go ahead and send those questions, but please do include the topic from today's event or some portion of the title for today's event in that subject line so that they know what topic that is and so that our team members that are monitoring that mailbox know they need to get that to myself and Ashley in order to get you those answers. So in a couple of minutes, we'll go ahead and wrap up. And in a couple of minutes, you are going to receive an email that's thanking you for attending. So a couple of things with this, don't delete it without reading it. If you're attending today's session for continuing education credits, while we do not issue those continuing education credits, we do offer contact hours to count towards those credits. And that email is going to serve as your certificate of achievement. And it will have the title of today's event, the date, and the number of hours for you to submit to your accreditation or certification body in order to get those continuing education credits. It is also going to have a link to our survey. As I mentioned in the beginning, we really would love to hear from you, and we'd like to know what you thought of today's session, what we could do for you in the future, including what topics you'd like to see. So we thank you in advance for taking some time to provide us with that feedback because it really does help us. So you're going to be able to access that a couple of ways. There's going to be a link in that email. Ashley's also placing a link in the chat for you, and you can click on that. It'll take you there. When you leave the session, you will also see a redirect that looks like what you're seeing on your slide now. We just like to give everybody a little bit of warning. You're going to see that. It's not malicious. It's not spam. It's not taking you anywhere you don't want to go. It's just letting you know that you're leaving our webinar software and that you are going into the CMS Qualtrics survey software. Now, if you didn't get this email, one of two things happened. Either the email went to your junk or spam folder because our WebEx Messenger is not on your safe sender list because it does not come from Ashley or I or WPS. It comes from our software. or you attended by phone and I don't have a systematic way to confirm your attendance. In either situation, you are not out of luck. Using that same education mailbox, you're going to go ahead and send an email with the title of today's session, letting me know you attended by phone. Let me know what phone number you attended by. Once I check that attendance, I can go ahead and send out a certificate of achievement for you. And before we wrap up, we have a couple of minutes, so I just want to check in one more time with Ashley. Do we have any questions in the chat?
Leanne, we have not had any additional questions come into the chat.
Okay, like I said, you have 7 days, so please feel free to send those in through that education mailbox. But with that, that is going to end the presentation for today. On behalf of Ashley, myself, and everyone on the WPS Provider Outreach and Education team, I would like to sincerely thank you for taking the time to attend today. We're all super busy and understand that carving out an hour or 2 hours will carve out if you're coming tomorrow can be kind of a challenge, and we do appreciate that. We look forward to your survey comments, and we look forward to seeing you on the session tomorrow. So with that, that does end the session today. So again, thank you, everyone. You may now disconnect. Have a great day.